before I started, I wanted to know how many of you guys were doing lateral at your programs right now, like no, let me see how many. Raise your hands up. It's amazing. Every year it's getting more and more. 4 or 5 years ago, it's 1, 2 guys that raised their hands. So definitely the lateral approach is becoming mainstream. And the best proof is if you go to any meeting, NAS, WNS, CNS, AOS, it has to be now a lateral session, lateral symposium, lateral talk, something related to lateral. It's a really good approach and very good way to treat the spine. However, you have to understand this is not PLIF, this is not a TLIF, this is a very different surgery, and it comes with its own set of complications, its own set of challenges, and if you're not willing to take it and do it for real, you much better keep doing PLIFs, TLIFs, you name it, but not to do that, because what you do is you're not only hurting the patients and having bad outcomes, but you're also ruining the procedure for us, for people who really cares and do it right. But my recommendation is pay attention, trying to do it the way that it is. It's amazing how it change your life as a spine surgeon. So these are my disclosure where we do some research and we try to actually advance the technique. And as Rod mentioned, actually a lateral approach, it can be applied to almost every level on the spine, from the thoracic spine to the thoracolumbar junction and then to the lumbar spine. So you go probably from T4, T5 all the way down to L4, L5. So 5-1 is a problem, and it's not because of the iliac crest. The problem is because at 5-1, what you have is not anymore the lumbar plexus, as Dr. Tubbs showed today, is actually the lumbosacral plexus. So actually you start having foot drop and all these things, And then the other point that I want to mention is when you were mentioning the fulcral nerve, actually if you're doing lateral 4-5 and you hit the fulcral nerve, is the only time that actually you can have a foot drop after lateral surgery. That is very rare, Few times you say, what do you mean? And then actually you have to be getting the fulcral nerve because that's the contribution of the lumbar plexus to the lumbosacral plexus and the sciatic. So it's very interesting. So you have to be in a really bad luck to hit that nerve and have a foot drop after this. So, and then the other problem with 5-1 is not only the iliac crest, the lumbosacral plexus, but even worse is that the iliac vessels, the bifurcation is already out. So these vessels are already running that lateral. So the landscape to put your retractor and do the job lateral is almost nothing. So you don't want to take that risk. So the best access, I would say, for 5-1 besides posterior is dead center, the A-leaf. It's really good corridor is right there, and you can do your job, yeah? So, and then when we're looking here, this is actually all the indication that we have been using the lateral for, and every point that you're seeing here, I've been using it somehow, obviously more on degen and deformity cases because they're more common in our practice, but tumor trauma and other things actually are good indications. And this is, for example, the ideal case scenario for a tumor application. You're looking here. Very nice schwannoma going out of the foramen. Actually, this tumor dissects for you the corridor. You just need to get in here, open the retractor. The tumor is like calling you for taking it away. And then, obviously, trauma, infection, deformity is a good example. And the question for you is, why having such a bad images on there? It looks weird. You see this? Take the lights down. I wonder to know why we're having such a bad definition there. Maybe it's my computer resolution, the screen. So anyway, and then don't forget this. This procedure works by doing indirect decompression. And as you're looking here, actually this monitor, that monitor in the center is a much better image, yeah? You guys agree with me? It looks like this is the one with the problem. So you're looking here, this case, for example, just by increasing the disc height and bringing the vertebra back, then you have the indirect decompression as you're looking here. Just by doing that, actually you open the canal without the need of doing laminectomies and this and that. But this is the way that the procedure works. But you have to be careful, because if you're not a good carpenter and you violate the end plates, they look great inside the OR because the gravity is not working with you. But then when the patient stands up, it will subside. You lost all your jobs. So you need to be careful that your job as a carpenter has to be very good. You know, when you're doing T-leaf, you really don't care. You just go and you just destroy that end plate. You put the cage close, and then no matter what, you're collapsing. And I would say in T-leaf is actually the exception when they don't subside. Almost all the T-leaves, you see some subsidence, yeah. But in this one, subsidence is a really bad enemy. So you have to keep that end plate intact. You cannot abuse the size of the implants, because the bigger the implant, the more pressure you put on the end plate, the more subsidence you get. So in other words, this procedure is not like this, yeah? This is not like a little game, a little joke, like all is good on this, You have to take seriously the lateral axis if you really want to have a good outcome. So otherwise, you're going to end up like playing operation, yeah? And you don't want that. So first requirement to avoid complications on the lateral is this. You really have to know the anatomy. If you don't dominate the anatomy, what you're going to face, that's going to be bad, And one of the problems that we have with the lateral axis, and especially for us, because all of us, we learn how to do lateral after our training. It's not like you guys that grew up doing laterals. So for me, it was very hard, because I went to a lab. They showed me, you just go through here, this and this and that. You put the retractor open, and you're there. But then I didn't know, what the lumbar plexus was. I mean, who cares? Yeah, when I was in med school, we're not doing nothing through the lateral access to that. In the residency, less. And spine, I was trained doing A-leaf, plifts, T-leaves, and everything else, nothing lateral. So why I'm going to spend time trying to learn a plexus that is complicated, that I'm never going to use it? So the problem is, and then suddenly we start doing surgery through that. We start manipulating that plexus, and then we start having complications. And then, unfortunately, we learn actually by hitting the walls. When I remember, I start doing cases, and then some patients wake up with femoral nerve injury, some patients don't. And then in the patient that waking up with femoral nerve injury, actually the monitoring was very good. And then when the monitoring was not good, actually the patient was waking with no problems. I was like, this is crazy, So I'm depending on how the penguins are walking this week, so not to avoid, where the sun is coming. So maybe it's my lucky day. So I was this close to abort and say, you know what, guys, I like your procedure, but I just cannot keep doing a surgery that I don't know when the patient is going to have. And then, obviously you see all these papers that we put together, and the SOLA Society helps a lot. So we finally understand that actually you have to be persistent, that your retractor always, when you go to 4-5, for example, you have to be right here in the front of the femoral nerve. And if you move the nerve from anterior to posterior, it will tolerate better if you move the nerve from posterior to anterior, yeah? And then the second thing that you have to understand is, besides knowing all this anatomy that Dr. showed today very good, is that this is not T-leaf, okay? And this is the big difference between the lateral and the T-leaf. So if you're looking here, when you're doing a lateral, so you are retracting these structures. All these nerves actually are peripheral nerves. So all these structures are post-ganglionic structures. It's a peripheral nerve. When you're doing a T-leaf, most of the time when you retract the exiting root or the traversing root, actually you are preganglionic, yeah? So if you are retracting, you're retracting just a root that is going to be contribution of a nerve. But in this case, if I injure the femoral nerve right here, is the equivalent if I do 3 levels T-leaf, and at each level I hit the nerve there, So the point is, if you look in this picture, this is the equivalent. I will always say, because I like cars a lot, but to me, the lateral minimal invasive is equivalent of a Ferrari, I would say, It's an amazing machine if you know how to drive it. If you know what you're doing, this is what happened to you, yeah? You die, and you die horrible, very miserable. You might better be driving a Hyundai or something. Excuse me, the Korean guys in here or whatever. You might be driving a Hyundai or Yugo, you name it, At least they move you from point A to B, Don't touch the Ferrari, yeah? So that's what we say in the big meetings to all these other guys that criticize the lateral. We say, listen, keep doing PLIF until leave. Don't touch the lateral because you're going to crash it, yeah? So, and then this is the problem because this is the complication. Watch this beauty, yeah? Full femoral nerve injury. You see the atrophy. And then if we look in here on this video, watch this patient. So if you look in here, this is we just examine the patient because sometimes you can fool yourself. He can flex the hip, but watch what happens when you sit in the patient 90 degrees. This is the right side, that is the bad one. He can have no extension on the right side. So left one is good. Take a look at the right one. It's nothing, no knee extension. See, this is true femoral nerve injury. And then if you look in here, it's showing this is all the sensory deficit. And then we just telling also, this one also has a little bit of obturator. So you're looking here, this is a really bad injury. You don't want to have this, I will trade any foot drop for this complication. Yeah, this patient, in order to walk, he needs a knee brace, needs to lock the knee because otherwise he is going to fall every time he's trying to walk. So how can you prevent that? Doing this procedure right. It doesn't mean that there is no way to do it. The thing is that you have to be very efficient. As I show you in the cadaver today, you have to control 3 variables. One is the direction of the retraction. So by using neuromonitoring or whatever, make sure that your retractor is in front of the femoral nerve. Second, the amount of retraction. You don't want to open the retractor like this. Great for you because you can see everything, yeah, but horrible for the patient because the more you move this nerve, the more chances. And the third one is time, yeah? And the best example is I took this one from David Okonkwo. David is awesome. You guys have to hang around with him. He's so smart. Everything that he says comes with some really good, meaningful explanation. So David usually say this. Just imagine that the femoral nerve is your eyes. If I put my finger in my eyes for 30 seconds, nothing happened. If I put it for 1 hour, I will be blind, yeah? So same thing with the femoral nerve. If I retract this nerve like crazy for 1 hour, no matter what, if you're retracting the nerve correctly, this patient is going to end up with an ischemic injury of the nerve, yeah? And then the last part is that also, don't forget there is different different types of nerve injuries, It's different if you have an axonotomesis, if you have a neuropraxia, So when you have a neuropraxia, that is, I will say, the list of the nerve injuries that is just losing the myelin or myelin block, this patient gets better in 6 weeks, And that's sometimes when people say, oh, I have this problem, and the patient wake up. We know problem after 6 weeks. But then if you have a real neurotomesis of axonotomesis, that nerve injuries are very complicated, and this is not the focus of today, but then you have to also understand and be able to recognize when your nerve injury is a neuropraxia and when it's an axonotomesis, when it's a neurotomesis, because the prognostic is totally different, yeah? And then also the idea is if you're gonna have a nerve injury, hopefully you only have neuropraxias because they're reversible, yeah? So how can you do that? Also, you have to get through the learning curve. Then look another stupid thing. You see this one? Bad carpentry. This surgeon in here, it looks okay, yeah? You see the cage a little more anterior than normal, but what you think happening in here? Anybody knows in here? You see Jacob, that my fellow, that it's been for a month, but maybe he can pick it up. What do you think is the problem in here, Jacob, with this cage? Exactly. So this surgeon actually, he had an intentional release of the ALL. Nowadays it's a hot topic, what we call the ACR, because doing deformity is amazing. But if you don't know that you injured the ALL and you put this cage like that, take a look what happened. This is a beautiful film. You see that? Imagine you taking this cage out. This is a nightmare, So you just have all the vessels are right here in the front. How are you going to negotiate this? This is a torture. This is a horrible. And these soldiers were thinking that just by putting pedicle screws, he were protected against the cage migrating. So see, it's a little thing. What happened in this case probably, if we rewind the moving here, probably the surgeon was doing his lateral case with no problem. Maybe the patient lose a little bit the position, get a little bit of rotation. He end up more anterior than he wanted, or when he was using instruments, things more anteriorly, then he get the ALL, And then that was the mothership of the problem. So you see, minor things can end up in a catastrophic, horrible problems. I can imagine what you do in a patient follow-up in your clinic with this. I mean, the surgery is a monster surgery. You have to get a vascular surgeon, and then I can imagine you trying to move the cava and moving this cage out of there. And then it's a big deal, yeah? So we look at the complications. So you have to recognize what are the major complications on the lateral approach. So one is obviously the lead complication of the approach is the lumbar plexus injury. This is a unique complication for the procedures. You do T-lift, you do PLIF, you do A-lift, you don't have lumbar plexus complications, yeah? So it's a unique complication of that, and actually the most frequent complication. So all the effort that you see on the lateral approach to the spine, all the time that we spend, all the sophistication in all these instruments and all these companies just to avoid the lumbar plexus complications. And the problem is, as you know, some companies or something, they don't know better, so they're more, for example, they're more like dedicated to how to navigate a lateral procedure. I mean, navigation doesn't do nothing to prevent the lumbar plexus injuries, yeah? Navigation is only telling you, you're in here, you're putting the cage in here, doing nothing. And that's the leading complication of this procedure. So you have to make sure, that's why that's your job. You need to be smart. You need to know exactly what are the problems with the lateral surgery. So when you're choosing what you're going to do, you know exactly where you're hitting, yeah? Then the second complication is obviously related to a hard-won insertion, as you saw that ALL release, damage in the end plates. All these things are important because, as I showed you at the beginning, in direct decompression, this is what actually works this procedure. So if you violate the end plates, then you have suicide and you lose your job, yeah? And then we have what we call a catastrophic complication, these two complications, vascular or bowel injuries, Unfortunately, when you have these complications, I always say you're breaching the standards of the technique, For someone to have vascular complications, you're really missing your planes, and also the bowel complication. Bowel complication only comes if you actually not dissecting the retroperitoneal structure good, Because as you know, the colon is a retroperitoneal structure, Want it or not, the colon belongs to the retroperitoneum. Only the rectum and a little bit of close to the cecum is a peritoneal. I'm correct or not? Yeah, so it's the only, otherwise it's retroperitoneal. So want it or not, every time you go there, we are retracting the colon anteriorly. So if you're going through the colon, it's because you're just going through and through. So you have to go posterior, move these structures, and as you saw in the lab, every time I put any instrument there, I have my finger in here because I know all the problems are on the front. Everything goes behind my finger. It's impossible to have a bowel injury. And in our program, we haven't had any vascular injury, any bowel injury, and I will say between all of us, we're doing more than 1,000 lateral procedures. Why? Is because one, always, every time we do a lateral, we treat it like the first case, I never go and say, oh, this is too good, it's easy, I can do it in 15 minutes. No, actually, every case you have to take it like your very first case, so you don't lose track, And the other thing is trying not to take too much shortcuts, because one of the problems for us as surgeons, we like to take a lot of shortcuts, and we are also, I don't know, it's part of our culture, but we like to go and say, oh, my way is the best way. These people don't know nothing. This is the best way. Unfortunately or unfortunately, on the lateral approach, I will say one of the success of this one is that there is a standardization. There is 7 steps, and you have to do one following the other one. And you don't go in step 3 until you go with step 2. Yeah, and then if you don't get successfully with step 2, then you must better not keep going, because then you're gonna start having problems. So every time I have fellows and residents with me, I always tell them, we make this procedure so boring that it's just 1, 2, 3, 4, 5, 6 steps. But we know if we do all of them, the outcome has to be good. So this is your game. How can you do? And every time the game is, how can I do that step better and more sleek every day, every day, every day, and then the outcome has to be good. So look at this, and the complications actually start on the clinic. So you look at this case, actually this is a case that I aborted, and I was lucky because actually one of the reps is the one who was asking me, what's going on in here? I said, oh my God. And actually I changed this procedure. I feel bad because I should know better. Actually, the patient sleep. I had to go out, talk to the family, and tell them, you know what, we're gonna do a T-lift today. Watch what's happening here. You're looking here on this image. Watch when this line is gonna go what supposedly is 4-5 in here. And at the same time, you're gonna watch these vessels, you know, how they're gonna move in here. So I'm gonna roll this video and pay attention to that. So you're looking here, as you go down, take a look at the vessels, how they go, see? When we go to 4-5, take a look where this vessel is gonna end up. See, it's totally in your way. You know, I can imagine if I were doing this case, I don't know what's gonna happen. Yeah, so this patient has actually what we call a transitional level. He has an early bifurcation, so the iliac vessels already bifurcate, and then they were running to lateral. And this patient usually is like a package, you know, like a transitional level is like a package because what is it? One is not only the lateral vessels, the vessels also lateral, but also most of the time they have a high iliac crest, and the plexus is not anymore the lumbar plexus, it's the lumbar sacral plexus. So it's like you're doing an L5S1 level, you know, but it looks like a 4-5 level. So these cases, you must better do something else. I mean, there is no point to really push in something than when you have another option. You see, so in the clinic start, and then not only this one for the big vessels injury, but watch the next slide. This is one of my beautiful complications, you know, and I have every complication that is on lateral, I've been having it, except by the bowel and the vascular injury. So look at this case. It's a very interesting case. And I like to look at the complications a lot because what I'm trying to do is why it happened, what was the source of the complication, and then not only that, but then how can I let you guys know the complication happened so you guys don't have the problem that I had before, because I know if I do that, we're just going to make the procedure better and the outcomes are better. So you look at this case. So what do you think happening here? Again, I'm going to keep pulling Jacob. Jacob, what do you think happened on this case? So you see, I did the approach from this side, yeah? And what is this? Somebody from the audience help me out. What is this thing? So it's a psoas hematoma, contralateral. Very interesting, no? So why do you think this happens, Jacob? Well, so, you know, obviously you go deep with the carbon, but watching here, this is something very interesting, yeah? So you're looking here, you see these little dots, yeah? They're segmentary vessels, yeah? One in here, this is where you should live. One in here, one in here, one in here. What is the one in here? You know, it doesn't exist. Actually, this patient, if you're looking here, they were right here, you know? So I should know better and identify this before the surgery when the patient was in the clinic. So this patient has an anomaly of the segmentary vessels. So when I was releasing contralateral, actually I went through this little vessel, yeah, probably start bleeding, but you know, you put some flows in your pack and I end up good with the surgery. And this patient was very interesting because day after the surgery, they start complaining of contralateral leg pain. And we say, you know, this woman is just whatever, you know, it's contralateral side, it's crying too much. Send her home, send her home. So she went home, yeah. No problem. And then the interesting thing is that she came 5 times to the ER, and the residents were like, every time they call him, again, this woman, you know, send her home, he has no femoral nerve injury, whatever. The 6th time that for the 6th time that she showed up, actually showed up with a full femoral nerve injury. Finally, the resident did a CT. And then he called me, hey, Dr. Uribe, I think this patient has a abscess, you know, they call an abscess. I said, well, listen, she has fever. No, obviously has no fever, CRP was normal. I said, get an MRI, and that was the MRI, huge retroperitoneal hematoma. I mean, psoas hematoma. Obviously, I went there, I opened from the other side, you know, all blood, and then the nerves, you know, the plexus was there, and then when I get in here, that thing started bleeding like crazy. That's what going back, then I identified the little artery there. You know, you coagulated, whatever, but the interesting thing is that this hematoma becomes so symptomatic is because if this hematoma was on the ipsilateral side, probably it will be draining to the entry point of the access into the retroperitoneum. Wouldn't be a problem. The problem in here is this hematoma was sealed because this fascia was intact, the cage was sealing in here, so it was creating a lot of pressure. So it was actually a very interesting complication. So you see here, I can prevent this complication by looking at the MRI pre-op, you know. So actually because of this case, now we're trying to make our own radiologists to make coronal cuts on the MRI. Not every center do coronal cuts on that. But you can do also is on the sagittal cut, you can follow the segmentary where it goes. So make sure that it's not into the disc space because you can end up with this complication for no reason, yeah? And then let's go these 8 points that I will say these are the 8 critical points. If you try to control these 8 points, you're gonna decrease a lot your amount of complications. So the first one is, as I told you, you have to understand the regional anatomy. If you don't know where you're going, it's better not to do it. Second is you have to, as Dr. James showed today, all these nice dissections using here. This is the quadrilateral lumbar. You see the ilioinguinal, the iliohypogastric, how they nice. They run in front of the quadrilateral lumbaros, and no matter what level you go, you can always injure them. That's why when I do the dissection of the muscles, I use these two hemostats, because if I found the nerve there, I just move it around, I just keep going, yeah? You go with the bobby, you hit it, you know? If you're doing surgery with your general surgeons and your spine surgeons in your program, and they do these big incisions, almost every patient will come with this bulging here, yeah? Because, I mean, if you open one big lumbotomy and you go with the bobby, these two little guys, they have to be there injured, yeah? And then, obviously, when you go into the psoas, you know that that's the femoral nerve and the other players of the game, yeah? And then, so you have to really have a good understanding of and then when you get into the psoas itself, you know how it is. See, this is 4-5 level, this is posterior, this is anterior. You know, this is the foramen, this is the L4 nerve coming out, and then joining the femoral nerve. So you see, you work right here. So what you do is you retract this nerve from anterior to posterior, and then you do all your job. So your game is, how can you get there retracted in and out as fast as possible, yeah? So, and to be honest, I always tell the resident, I prefer to do the percutaneous because I don't want to see this thing in real life. So scary, you know. The retroperitoneum looks like a bunch of fat little vessels, everything bleeds. You get into the psoas, and then you see all these nerves. They don't come with a sign, femoral nerve obturator, so that's the problem. You know, sometimes they say, oh, it's nice to do open dissection of the psoas, but then I always tell them, how do you know that you're in the front of the femoral nerve and not the obturator? You know, they're close together, yeah? So that's one of the problems. That's why we like to use monitoring, because the monitoring can help you a little bit, you know. You know, you're stimulating the femoral nerve, you should have, you know, abductor, quadriceps, all these muscles working together, yeah? And then this is very important again, don't forget, positioning is the mothership of every complication. Perfect AP, perfect lateral, not only for avoiding vascular and bowel complication and not to put the case to posterior, but also to do a good carpentry, yeah? You keep these templates intact, you keep it parallel, you don't injure them, then you can have good indirect decompression, yeah? And then this is also very important. This is how we started doing this procedure. You see here how we jackknife this poor patient. We were breaking this table like crazy. So obviously this iliac crest go as low as you can. You can access almost whatever you want, but the problem is every time you break the table, the more you break, you put tension on the femoral nerve. You know, if this is the femoral nerve and I don't break the table too much, then femoral nerve is going to be like this. But if I break it a lot, I'm going to put the nerve under a lot of tension. So that nerve is going to tolerate less retraction when the nerve is fluffy, kind of loose. So your game is, how can you do it instead of that, doing something like this? You see, so what we're doing now is we just bend the table enough that we can get to the level that we're going, you know? So you want to bend a little bit, and the reason why you want to have a little bit bending is if you don't bend at all, the muscles, you know, the external oblique, internal oblique, and the transversal, they become this thick. So it becomes a torture to dissect them. If you break a little bit, immediately they get a little more thinner, and they're very easy to go through. That's why we dissect a little bit. And also, you don't want, because if the patient, let's say you go into 3, 4, the upper levels, if you don't break a little bit, then you have to deal with the ribs. So you don't want to start your case, first thing that you see is the pleura and get into the chest for no reason, yeah? So you break a little bit, you move the ribs a little bit out, you sure that you are into the retroperitoneum, so you don't need to dissect diaphragm or get on these other points, okay? Then, that's what I explained you. When you dissect the abdominal muscles, you can find them, in this case, you see, it's the ilioinguinal or the iliohypogastric, you find them, you move them around, and you just keep going. And then you don't want to have this, yeah? So this is the complication, classic bulging, because you injure one of those nerves. And then you have to be careful with your finger. You know, at the beginning, we also were like, okay, once you get into the retroperitoneum, oh, release the adhesions of the Actually, that adhesions end up being some of these guys, see? So you don't want to rip off all these nerves, all these structures that we were thinking they were adhesions. So actually, we were having nerve injuries just before we put in the EMG monitoring. So what you need to do is you release exactly where you're going, put your finger up front, and then you do your job. Not anymore, this like a release, 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 you know. You're doing A-lift with your access surgeon. You see that they love to do that. When they do the incision, they go with this sponge stick, and they just go and they move everything around. They're like a real butcher, yeah? So we don't want to do that, yeah? And you have to control that part. And then they, you know, when I do surgery with them, they call me like I'm a little sissy or something like that because I'm too much, you know. But anyway, so we're trying to protect them. And then the next one is you have to, I mean, if you're really trying to do this procedure percutaneous and you're working through this small incision and you don't see where you're going, you must better have a really good monitoring system, something that has what we call directionality. So I know exactly if I'm stimulating anterior or posterior, and make sure that I know that I'm in the front of the femoral nerve. And I show you a little bit of video later on. And then this is the other one that you don't want to have, yeah? Don't forget, very small opening of the retractor. You see in the example that I was doing it, 2 clicks this way, 6 clicks this way. Every retractor is different, so you have to find a way, but the message is just enough to put the cage in a very tight situation, you know. You don't want to open too much. Good for you, horrible for the patient, yeah? So we're trying to protect the patients. And then, obviously, subsidence. You see here how beautiful it looks, yeah? So you see here, bad subsidence. There is no indirect decompression in this case, yeah? So we're losing everything that we did in here. So what was the problem in this case? Huge cage. You see this space, the height is probably 4 millimeters, you know? And then you look at this space is probably 8 or 10. And this surgeon, we were trying to force probably a 14 millimeter cage. They look great in the OR, but once you stop this patient, you stand them up, they pile up, and this is what you have. So this patient, what is facing? He may fuse. You have to go later on and do a big, you know, foraminotomy or laminectomy because he still is going to have the radiculopathy, yeah? And then the last one is obviously no over retract that. So now this one is just to show you the difference when you break or not. And this is actually a cadaver specimen, but if you look in here, the little video, this is the femoral nerve actually. This is anterior, this is posterior, this is the psoas itself. I'm just gonna show you what happened when you break the table, okay? So you're looking here on the video. So once we break the table, see, right now it's see when you break the table, how much tension you put on it, you release it, take a look how nice is the femoral nerve, it's loose. Then you break it again, take a look how much tension you get. So you want to work in something like this, yeah? Not on this amount of tension, yeah? Because that nerve is gonna tolerate less retraction than one is not, you know? So this is a good proof that thing actually happened for real, yeah? And then the next one is, I'm gonna show you how the neuromonitoring works. So in this video, obviously I'm standing on the posterior part of the patient and we started stimulating with the directionality. So you're looking here, so you're working on L4-5 level, so you have the retractor right there, then I'm stimulating anterior, so you see the numbers are, let me put it here. The numbers are, and then as I was rotating posterior, the numbers were lower, then as I keep rotating anterior, the numbers are going to be more lower posterior, and then when I start going anterior, using here, the numbers are gonna go up, yeah? So what is telling me right now that? So if we're trying to put that thing on a cadaveric dissection, we were pretty much right here, yeah? If this is posterior, this is anterior, I was with that dilator right here. Ooh, what happened? So that's why when I was stimulating posterior, the numbers were low, but it was stimulating anterior, the numbers were high because the stimulus has to go all the way here and then try to go here and then catch and travel to the femoral nerve. That's why you need more energy anterior than posterior. So that's the ideal case scenario, yeah? Now let's see another case. In this case, for example, I end up, when I have this kind of configuration, I have to take the dilator out, find a different entry point more anterior until I have different readings. So you're looking here, in this case, when I stimulated posterior, there were higher numbers. When I was stimulating anterior, there were lower numbers. So take a look in here. So I was stimulating posterior, high numbers, yeah? Well, take a look, when I go anterior, there were lower numbers, yeah? So what it's telling me right now is actually, in that case, if we look in here, I was like this, yeah? In that case, I was like this. This is the worst thing that can happen to you. if I put the it might look good on the x-rays, you're in the posterior third, nice, well positioned. But if you put the retractor and you open it in here, you're gonna move all these nerve structures up front, yeah? And then you're gonna end up in a really bad complication. Then let's look another case scenario. In this case, I put this little marker in here. This is anterior, posterior. This marker is just in front of the femoral nerve, yeah? So ideally, you have to put your posterior blade right here because that's the posterior third of that. So we're gonna do the example, for example, let's say that you're using your generic EMG system from the hospital with no directionality. So you're gonna put the dilator, and then once you get close to the nerve, the technician is going to tell you, hey, Dr. Uribe, you're very close to the nerve. And then I'm gonna ask him, what is the nerve? And then he said, I don't know, the nerve is right there. So what they tell you, go anterior, way up front when there's no nerves. So you go anterior, you try to get again readings, then the numbers are gonna be great, high numbers. But the problem is, if they ask you to go to anterior, want it or not, you have to end up moving the retractor up to here. So you can put the cage at some point, yeah, because you cannot put the cage on the cable, too much anterior. You need some area because you put in a 22 millimeter width cage, you need to somehow put it there. So I'm gonna show you in here that example, okay? See if you guys can follow me. So I get in here, let's say I get with the, I get with the stimulator. So I'm starting stimulating in here, and this is with directionality, it's going to tell me, okay, so you are close to the nerve, so I can put the retractor right there, yeah, because they're telling me lower posterior, higher anterior. If this one was a generic system, I will go more anterior, yeah? So I go more anterior, and if I do a stimulation right there, it's going to tell me that actually the numbers were very good. But the problem is, by the time I cannot open the retractor right here because it's too much anterior, so I have to end up moving the retractor posterior. But see what happened to the nerve, watch. You see that? You make like a sandwich. So actually, the muscle, instead of becoming your friend, is becoming your enemy because it's gonna be more mass effect pushing on the femoral nerve, and then the transverse process is waiting for you to get more crushing on that. So that's what I always say, I prefer to be dead clear in front of the femoral nerve instead of leaving a lot of muscle in front, yeah? Because by the time you move the retractor, actually you create, that's the classic example, actually it's a paper on the literature about that. They say that the patient wake up with a femoral nerve injury with a really good EMG readings, yeah? And this is what people don't understand. The EMG, the only thing that do EMG for you is help you out to place the retractor in front of the femoral nerve. But after that, it's not gonna tell you that you're not going to injure the nerve. And this is the classic example. You can have a really good readings on the EMG, but then the patient wake up with a deficit. Why? Because you move all this massive muscle maneuver through the TP with the nerve, and then you have the injury. So that's why when you're doing these cases oblique or you go more anterior, by the time that you put the cage, you have to do it like this, because I can imagine moving all this massive muscle that, and you can learn a little bit from that. If you look on the 90s, Dr. Shaffrey, were you at the time of Reagan and McAfee doing endoscopic laterals on the 90s? And Dickman a little bit?
Yes, I've done them before.
Yeah, so it was a really elegant way to do it. They used to put the endoscope on the retroperitoneum, and at that point, what they used to do is clip the segmentaries and move the muscle from anterior to posterior and from posterior to anterior. The problem is they were having a lot of nerve injuries, and that's a good explanation why. Because if you move the whole thing massively, then you have that. That's why if you go transpsoas, you might better stay very close to that. If you prefer not to go transpsoas, you might better move as fast as possible because you're gonna have this other problem, yeah? And you don't want to put this cage too much oblique because you're gonna hit the femoral, the foramen on the other side, you get radiculopathy, yeah? So this is, you see, it's a very little nuances, but if you don't pay attention to this, then you pay your dues, And if you do 100 cases, and unfortunately, you have 20 patients that actually the femoral nerve was a little more anterior, then you have a 20% rate of femoral nerve injuries. You don't pay attention to this. So that's why some surgeons say, I don't do 4-5, I only do 3 or 4 and above, because at that levels, you don't need to deal with more with not too much with the femoral nerve. But I will say one of the most nicest indications of the lateral is 4-5 actually, and it's a very common area to go. So there shouldn't be a reason not to do 4-5. And the problem is if you only do 2-3 and 3-4, you will never become a good lateral surgeon because the volume is not too high. Once in a while you go and do it. I mean, how are you going to get to the learning curve, yeah? And then the next one is what Rod showed you, what we call expanded application. I don't want to spend too much time in here, but this is all these applications, we can do it also. Spondylis, grade 2, subarthrosis, for laminectomy, kyphosis. Deformity is a really good application, as Rod showed it. And then a trauma, tumor, and sometimes an infection, yeah? So when you're trying to do deformity, as Rod explained, is becoming more complicated. This patient has on rotational, so you have to do one level at a time, and you have to derotate the patient, because if you don't pay attention to that, you start having problems. But it's very powerful if you do it the right way, as you see here. How much correction can you get by cutting the ligament and manipulating the anterior column using the minimal approach. So we're just gonna go fast on this part, and then what do we learn doing actually deformity using the minimal invasive lateral? I'm gonna give you a couple of tips, but this is what we do. So for example, we like to go from the concavity. I'm gonna tell you later on why. The most important thing is because the concavity usually is the one that gives you the access to 4-5, yeah? So you're looking here, if I'm trying to get 4-5 from this side, it's gonna be a nightmare. Not only that, if I'm trying to do, let's say, this level from the convexity, I'm gonna end up almost below the axilla. I'm gonna end up like in here. So you have to go to the chest, I mean, it's horrible, yeah? You go working from the concave side, all the vectors, you're looking here, all they are pointing to the same point. So you actually minimize the amount of incisions and trauma around it, yeah? Then you have to be very careful of this, yeah? You have to recognize the rotational component. If you don't adjust at every level, then you will die in problems. And looking here, see this patient, take a look how anterior is this incision for the high level. If I go straight through here, I'm gonna go through this colon, through the liver, who knows through what, But how come this patient didn't have any injuries? It's because first, I knew it, that the patient was, I was going high, I was going more anteriorly, but every time I go through the muscles, my finger was going all the way back into the quadrilateral as Dr. Tubbs showed you today. Get into the quadrilateral, that's your plane, and then you move your finger up front. All that structure has to move up front no matter what, because the colon, all these things can move with you. You just need to mobilize them right, yeah? And then again, the table has to be adjusted at every level. And then obviously put wide implants, and then obviously consider this. Once you get to the learning curve, you want to start manipulating the anterior longitudinal ligament intentionally, no unintentionally, and then you start really giving good lordosis. And this is a topic for later on, but it's very, very powerful. And then vascular anatomy is very interesting on deformity. And we know that usually the vessels rotate toward the concavity. I'm gonna show you in the next video how this vessel moves, so you have to be careful. In this case, actually, I approach it from the concavity where the vessels are going, but you have to understand something that I want to show you on this picture. So take a look at the vessels in here. This is the cave in here. As we go down, you see how they're gonna end up more on this side, yeah? So if we look in here, and if we follow the vessel, you see how it's moving? It's moving, you see, now it's becoming almost right there. But the interesting thing is that if you look at these vessels move, they're not attached to the vertebra itself. So they move toward the concavity side, but they're not attached to the annulus because they're not, embryologically, they're not even belong one to each other. So they're moving here. Again, what you need to do is your finger goes posterior, you move everything anterior, then you put your dilator. You don't have to deal with the vessels if you do it that way. But if you go straight forward, obviously you're gonna hit the vessel, yeah? So again, dissection is very important in here, okay? Then I'm gonna give you a little of these points why the concavity approach. So one is when you break the table, immediately you start correcting the coronal deformity. Second, you release all the contracted tissue on the concavity. Third, definitely helps you with deformity correction. Give you approach to 4-5 easily than the other one. And then it's very good in terms of first thing that you do, you restore this height and do the indirect decompression from the concave side right away. Then you decrease the number of incisions. You see here, all the incision goes to the same point. So one incision, you get 2 or 3 levels. The bigger the deformity, the less incision you have to do during the concave side. And then if you have this vertebra that has this asymmetric shape, you can use asymmetric cages that works very good from the concavity side. We don't use it very commonly, but it's a good way. You know, some patient comes with, you know, when they have this bad osteoporotic adult deformity where the vertebrae not only are losing height, but also they're getting wedged, you can actually help with these asymmetric cages. So then, just to finish, I want to show you this image in here. So these two images actually from good friends of mine, they were showing to me, and I like to show it on these meetings because I want you guys to help me out to pick up how many mistakes are in here. Just imagine just one of these magazines picking up, you know, what is the problem in here. So you guys help me out to find a lot of problems on this case. So this surgeon he was thinking that he was like a badass lateral surgeon, but you will see how many problems we have in here, okay? So Jacob, help me out with the first problem in here, in this image. Okay, so retractor is, this guy is doing like a massage of one of the segmentaries. That's amazing, yeah? Maybe he's putting some, I don't know who was doing there, yeah? So this guy is like, I don't know, there's nothing to deal with here, okay? Okay, second problem in here, somebody else help me out, not Jacob anymore.
Looks like he's using cerebellar retractor.
Yeah, but let's stop down. Stay more on this picture todavía. We have still more problems. Exactly. So this patient is rotated like crazy. What's this spinous process? Right here. So this guy not only was lost on the superior inferior, but also was lost on the rotational. You know, who knows this patient is going to end up having a vascular injury? Who knows where you are? I mean, when you have a case like this, you are at the mercy of being lucky, yeah, because you're losing control of where you are, yeah. So you have to be very careful with that. And then what about this one? What you guys see weird in here? Yeah, all these retractors, you know, this guy, what he's doing in here? It's like to me, it's like someone that is lost, you know. 1, 2 cerebellar retractor. This guy is like doing like an anatomical course on like showing all these things. I mean, you don't need to do that. You see that. The incision this size, you just need to put your finger and then you get there, you know. Probably he was trying to go open and find things on there, but the problem is when you confuse doing minimal invasive like an open surgeon, yeah? So you do minimal invasive or you are open, but don't mix it because that's when you end up, you know, it's kind of, and then the problem is this patient have a complication. He's not gonna say that he did an open. He's gonna say, that freaking minimal invasive lateral thing doesn't work, you know, all these things, yeah? So you have to be very careful, yeah? It's a lot of little tricks, a lot of little details. If you follow them, this surgery is awesome. If you don't follow them, please don't do it. Do lateral, do T-leaf, do PLEAF, do posterolateral fusion, anything. You know, those procedures, they take more abuse than this one itself, you know. So it's actually a really good option, and then don't be like this guy, you see? The solution is right here, and he decided to put the bucket in the head, you know? So it's just crazy, yeah? So if you know that the solution is right there, why are you doing this? People are kind of weird, yeah? And then don't forget, sometimes you have to do a lot of things to make the thing happen, yeah? So see, in this situation, actually the best way to do that, but the guy get away from that, you know? So also, don't forget, use your common sense. Common sense is very important in what we do every day, you know? Sometimes even if the next rule is this one, it just doesn't look good to you, do whatever it takes so you get the damn job, do it, yeah? So then the last one is, you guys want to learn really good MIS lateral or something. For some reason, I have an expected opening for the fellowship next year. So you guys feel free to contact me or talk to Jacob. I think we have 2 residents in here that can tell you how the experience in Tampa. You guys will be very welcome. Thanks very much and open for questions.